Thank you for inviting me today. I'm glad to be here to talk a little bit about our project. I am, as Dr. Neeson had said, I'm from Metropolitan State University in St. Paul, Minnesota, and we have developed what's called an Advanced Dental Therapist Practitioner program at our university. So we are one of the two dental therapy programs that is actively educating the mid-level providers in Minnesota. Just with a little background, and I'm going to kind of go through some of this quickly. It's been interesting how many times the Surgeon General's report from 2000 has been referenced today, and also the call to action. But those led to the American Dental Hygiene Association discussing the access issues in the United States and eventually coming up with competencies for what they called at that time, the Advanced Dental Hygiene Practitioner. And I just mentioned that because those are the competencies that we based our program on at Metropolitan State University. Along with that, then in 2009, the Minnesota legislature passed a law that added dental therapists and advanced dental therapists to the workforce in Minnesota. At that same time, our program was beginning. Our first cohort of students graduated in 2011. And in 2012, the university opened their own dental clinic for clinical education for the advanced dental therapists. One comment I'd like to make related to the first cohort of graduates is we have a couple of graduates who work for Appletree in various different programs, and actually one of our third is going to the Appletree Rochester program, which Deb Jacoby had talked about earlier. Let's see. A little bit about our university is we are based in St. Paul, Minnesota, so we're an urban university, and our mission and vision is dedicated to serving underserved in the community, to serving adults and communities of color, and providing community service for the area. We are also, and I don't think I put it on here, but we're a public university. Our Master's in Science and Advanced Dental Therapy is the degree conferred upon our graduates. And with our program, we're somewhat unique in the sense that students who come into our program are already practicing dental hygienists. So when they graduate, they have dual licensure in both the scope of dental hygiene and dental therapy. And with dental therapy in Minnesota, most or a good chunk of the scope of practice is restorative care. Oh, let's see. Let's keep going here. And this is just a real brief slide about our program. It's hygienists come into the program with a baccalaureate degree in some area, and then they will receive a master's degree. And of the 44 credits they will receive, 3/4 of them are in dental clinic-based courses, and 1/4 are in interprofessional studies. And this is actually a photo of one of our students in cohort 2 who are actually graduating 2 weeks from today. And Jenny is treating a patient in our Maplewood clinic. Our patient schedule is pretty full. We're pretty busy there, and we have 2 requirements for patients to be seen in our clinic. Number 1, they must not have dental insurance, and number 2, they must be at or below 200% of the federal poverty guidelines. What happens, what actually works real well with us is the picture on the top is a shot from outside the building. And there's also a large community clinic in the same building that we're located in. They're a very large Medicaid provider. So we have a real good relationship in that if we get patients who have medical assistance requesting services from our clinic, we refer to them. If they have patients who do not have insurance in their clinic and are unable to afford care, they refer our way. So it's a very good relationship. And as you can see, we operate on a pretty reduced fee schedule. If, just depending on the number of teeth that patients need to have taken care of, but the maximum amount for their restorative care will only be $100. Along with that, yes, we do have patients who are still unable to afford care, so we do have other avenues for uncompensated care and also applications and things for patients to go through to receive pro bono care. Some of the projects we used the DTAF funding for is one of the things is that we wanted to build community awareness when the clinic was first opened. And back to one of the earlier slides, we opened the clinic in January of 2012, so we've been open less than a year and a half, but we wanted to have some information out to the clinic, so we hosted an open house, and this is a photo of our open house with our university president, Dr. Sue Hammersmith, cutting the ribbon there. There are also many stakeholders and funders in the picture. One person I'd like to point out in kind of the purple or the blue is Ann Lynch. She, at the time, was a legislator in Minnesota, and she is responsible for the legislation that was introduced. She is now gone to work for the governmental affairs branch at the American Dental Hygienists Association. Okay. Then we also wanted to introduce the dental therapy role to the community. One piece we weren't real sure about how this was going to work was going to be the patient recruitment. We weren't sure how the patients were going to accept this new mid-level provider. Do they want to be seen by students? How was this going to work? So we kind of developed this big patient recruitment plan, and either fortunately or unfortunately, we didn't really need it. We started the clinic, and then with 2 weeks of opening the clinics, we already had a 2-week waiting list. And our current waiting list is actually more like 100 than 60. So, like I said, good news, bad news is that we have a lot of patients coming to us, trusting our students with their care. The bad news is, you know, I'm sure this is just scratching the surface of the need that is out there in our community. Another thing that we were looking at was how could we do or work with patients on education and also oral health literacy. One of the things that we decided to do with the DTAF money is that we purchased the KZ patient education system that is cloud-based, and then we have iPads in each of the operatories. So then with that, the students are able to pull up educational segments in KZ, for example, discussing periodontal disease or the need or what you can expect when to have scaling and root planing, things like that. So there's a lot of videos, a lot of diagrams, which seem to work really well. And along with that, there are a lot of PDF patient handouts that come in both English and Spanish, which again has worked real well with us because we do have I would say probably about 15% of our patients coming through the clinic that Spanish is their native language. And also with the technology, we purchased intraoral cameras for both documentation of care that is going on and also, again, patient education. So we can take photos of teeth of decay, show patients what we're seeing, or maybe areas they need to work with hygiene better. Again, it's worked really well. We are kind of in the beginning stages of our community outreach and collaboration at this point. We are putting together, we have some various oral health education and prevention programs we have given in the community, and we're also very lucky that we are also in our building are the Ramsey County Public Health Nurses. That's their headquarters. So we are beginning to work with them to find out what their needs are or what they view the community needs as, so we can get some more of that information out in the system. And we're also doing health fairs. And again, just starting this semester, we started clinical rotations for dental hygiene and dental assisting students who are at some of the local community colleges. So again, they're getting to work with the dental therapists and have a little bit more information about that, how that whole mid-level provider role works. Here is also a pilot project that we're working on that through money we received is that Metropolitan State University has a pretty large School of Nursing. And with that, one of the projects that the School of Nursing works on is that across the street from the university, there is First Lutheran Church, which runs the Love Grows Here Wellness Center every Thursday evening. And the focus of the clients who come to the Wellness Center are primarily homeless or transient housing. And so the nursing students do blood pressure screenings and also foot care. And so we were approached by some of the nursing faculty asking if we would like to come out and maybe start to do some oral health assessments or possibly even care in the dental clinic. So we started in the fall doing this on a real pilot project, just small numbers to kind of find out how it goes. But the thing we're finding out, which is not a big surprise with these folks, is the biggest barriers for them are the cost of services and transportation. So we are providing dental services free of charge. And then also with some of the DTAF funding, we have purchased bus tokens and cab vouchers so the patients are able to get transportation to the clinic. And I just wanted to throw in a little bit of survey, or this is a little part of our needs assessment. You know, and if you look at this, basically what it's, I guess the take home for me is that about half of the patients coming into the wellness center, it's been over a year since they've had any dental visit whatsoever. We've also done some patient satisfaction surveys with our patients. Interestingly, of the people returning surveys, 100% said they'd recommend our clinic. 70% said without our clinic, they're not aware of anywhere else they could go to get care. And here's one that Amos will enjoy. It says, given the option to visit an advanced dental therapist or a dentist for your next treatment, who would select the advanced dental therapist? And 2/3 of the patients said they would choose the advanced dental therapist. Some of our future plans, we're looking to increase our clinic capacity, reduce our waiting list. The idea of swapping rotations where our advanced dental therapy students will be going out to the wellness center to do screenings, where the nursing students will be coming into our clinic to get some more training and education with oral health care issues. We have more community outreach projects started. We're in the process of formalizing or a tobacco cessation program. And again, working on the whole oral health literacy. One of the things that we have been alerted to is the Teach Back toolkit. And we're gonna be adding that to our curriculum for the next group of students. This is my next group of students, like I said, graduating 2 weeks from today, and they are very excited to do so. So thank you very much.
Thank you very much. Thanks for the opportunity to be here. And we're also very grateful to the Dental Trade Alliance Foundation for allowing us to develop an oral health curriculum for our new medical school. So I'm at the Commonwealth Medical College, which is an allopathic medical school in Scranton, Pennsylvania. And some of you may not have heard about it, so I wanted to say a little bit about our school before I go into the rest of my talk. And TCMC, as we call it, was actually founded as a result of a demonstrated community need, because a significant proportion of the physicians practicing in Pennsylvania are expected to retire over the next decade. So basically, the school was established to address that need, the anticipated physician shortage in our region, northeastern Pennsylvania. All right, and this is our mission. You can take a minute to read that, but we're basically a community-based medical school. Our curriculum is very patient-centered. We focus on interprofessional care and using an evidence-based model of education. All right, so that's the map of Pennsylvania, and we're located in the northeastern part of the state. And this is our new building, which we moved into in May of 2011. All right, so now to talk about our program that was funded by the Dental Trade Alliance Foundation. Well, what Linda didn't say when she was introducing me was that before I went to medical school, I was actually a dentist, and I was actually board certified in dental public health. I got board certified in dental public health in April of 2002, and in August of the same year, I started medical school at Penn State. So when I got to TCMC, it kind of made sense. I was still receiving, on one of my old emails, I was still receiving a lot of emails from the dental public health folks. And then I heard this announcement about the Dental Trade Alliance Foundation giving out funding. And it made sense. Well, I do have the background. Why don't I just apply for this and see what happens? So we wrote up a proposal to develop an oral health curriculum for our medical students, and we got funded that year, fortunately. So what exactly have we done? Well, we've done a number of different things, but one thing is that rather than reinventing the wheel, we decided to leverage on some of the pre-existing resources. So some of you are familiar with the Smiles for Life online curriculum, which was developed by a group of people, including family physicians and dentists, but it's basically for primary care doctors to educate them about oral health. So we've focused on using that curriculum, not the whole thing so far, but we have used that, and focused on some of the modules that emphasize the connections between oral health and systemic health, dental emergencies, and then we've also been doing fluoride varnish applications where we've been having practical sessions with our students. I definitely couldn't do this alone, and again, even though I had the dental training and the dental background, I thought it made more sense to involve my dental colleagues in the community who were actively practicing. So we recruited a number of them. We had a lot of support, and they've been involved in doing the teaching, actually. So they come, and they're the ones who actually either go through the module on oral and systemic connections with the students. We have the dental hygienists who have come and talked about their profession and who have also demonstrated fluoride varnish applications. We're also developing partnerships with our other community agencies and programs like Head Start. We're hoping that we'll be able to take our students into the Head Start program so that they can actually do the fluoride varnishes there. That hasn't happened yet, but it's one of the things that we've been working on. And Scranton Primary Care Center, which is one of our community health centers in Scranton, they have a program where they have residents coming in to learn about oral health, and we're also planning to partner with them as well in educating our medical students. So an additional partner is our residency program, the Wright Center for Graduate Medical Education. They've been very involved in training their internal medicine residents in oral health, and we're also going to be working with family medicine residents as well. All right, so what did the funding allow us to do? Well, in addition to what I've already said, it allowed us to actually give honoraria to our speakers. Now, I said we did have a lot of community support, and really our speakers were willing to do this. We actually had to kind of beg some of them to take the money because we were like, well, we do have a grant and we have to spend the money. So it's heartwarming and encouraging to know that they're willing to do this for free. And we told them that, when we don't have money anymore, it's okay, but right now we have the money and we'd like to pay you this. I've also been able to go to a few regional meetings. I've had a student intern that we were able to pay to work with me on this program. We've been able to purchase fluoride varnishes, and also we're looking at getting dental anesthesia simulator models. We actually just have one right now, which we're sort of trying to see if we can have look at other options to figure out what's the best one so that we can also teach our students how to give dental injections. So if anybody here knows any company that makes those, especially the ones that have the indicators that tell you when you're in the right spots, I'd be interested in talking to you. Again, we're a new medical school. We haven't graduated any doctors yet. We've graduated people from our master's program because that's just a one-year program, but our first group of medical doctors will be graduating next month, and we're very excited about that. But right now, all 4 classes of medical students have had some level of oral health training. So hopefully our students won't be the ones that go out and tell people that oral health issues don't matter because they've had this training in addition to the fluoride sessions that we've had and the, well, actually what we've been doing is that we have an oral health workshop, and that's when we've had an oral surgeon actually come in and give the overall talk from the Smiles for Life curriculum about the medical, about the systemic and oral health connections, and also about dental emergencies, and then the hygienists talk, and then they do the demonstrations of fluoride varnish application, and then the students practice on each other. And we're still working on getting them to get out into the community and have them practice. I have them actually apply fluoride on real life people, real life patients. I've also been asked to join the Oral Health Advisory Committee of the Pennsylvania Academy of Pediatrics, and be involved in in what they're doing in terms of advancing oral health in the state. All right, so some of our unforeseen but fortunate consequences of this program is that I was fortunate to participate in the Harvard Macy Institute for Health Profession Educators, and my project was on mental to dental. That's what I called it, because my big thing was having a holistic, a comprehensive approach to healthcare. And you'll probably all agree with me that we tend to treat mental health issues and dental issues as if they're not really part of overall health. So that's one thing I was trying to address. And because we had some pushback from some of our senior classes, from some of our other students about this program, they didn't understand why they had to learn about dental stuff when they weren't in dental school, for example. So I developed a series of cases where we emphasize the importance of learning these things. So, for example, they went through a case where there was an elderly patient with altered mental status, and he got treated and went home and came back with pneumonia, and it was all because of a dental infection that hadn't been identified and treated in the very beginning, and they went through similar cases as well, just emphasizing the importance of addressing all these issues and the importance of oral health care to systemic health. I was also privileged to be a recipient of the Herbert Nickens Faculty Fellowship, in which, again, I said I would continue to work on my Harvard Macy project, and some of the funding from that was meant to support that project. And then perhaps one of the biggest unforeseen consequences was, before I go there, these are just pictures from our training program. We've also gone to school nurses and done education among the school nurses. So those are two pictures of two separate events with school nurses. Yeah, so this was one of the very, very unanticipated consequences. Cham Sante is a second-year medical student, and during the summer between her first and second year, she had gone to Guatemala. Now, when their class had the oral health workshop, I had just mentioned in passing that, well, some of them might be doing summer projects, they might be going abroad. If they want some fluoride, they should come talk to me. And then I happened to be in France for part of this summer doing an international teaching fellowship, and I got an email from this student saying something about how, she's going to Guatemala and blah, blah, blah. Is this what I was talking about? Could she get some fluoride? And I was like, well, I'm actually in France right now, but, well, if you go into my office, somebody might be able to help you, So anyway, so she got some fluoride varnish from what we had purchased with our funds, but she also, if you read that slide there, she actually used her own money, and purchased supplies and all of that, and I was like, what, if you had told us earlier, we could have helped you plan it. You shouldn't have been using your loan money for this. But look at that. So she estimated that she applied fluoride varnishes on, over about 180 people there in Guatemala, and she said it that, when they asked people at the clinic, what their needs were, the greatest needs were oral health. And she really became a champion. When she came back, she told me that she was willing to talk to the first year class because she thinks that they'll probably feel better, they'll probably accept it more coming from a medical student than just me telling them why they need to learn this. So yes, when we had the oral health workshop for the current first year students, we had Cham come and talk about her experience, and I think it really made a difference. So, and then she had actually used her own money to buy toothbrushes as well, which I'm sure she could have gotten donations for, but anyway, and those are some of the children that were brushing their teeth with the brushes she had purchased for them. So, again, this is just some of what she had shared with students, but at the bottom she says there, stay tuned because she'll be doing another presentation, because she got the fluoride from the money that was funded by our grant. So we're really very grateful to the DTF for that. Another aspect of our program is we have a pipeline program called Reach High, and this introduces high school and college students to health professions, not just medicine. So, and as somebody who's been trained in medicine, dentistry, and public health, I'm very involved in this program, and I've talked to them about all the different professions. But somehow oral health has become a big part of that too, and this was not really anything, I wasn't responsible for this, but they have a health fair during the summer as part of the program, and if you can't read it, that poster there says oral health, and then here's a picture of, the oral health table, so they were educating people on how to take care of their teeth, and I think that's just very interesting and very important that, at this young age, they're understanding the importance of oral health. All right, so strengths, we've had a lot of institutional support. Being at a new medical school, I've had a lot of support. I think it's a great opportunity because it wasn't like I was trying to fight traditions that had been on for 100 years or 50 years, but we were able to do a lot of things just because we were a new medical school. And we had a lot of community support, obviously the funding from the Dental Trade Alliance Foundation, and also the interest at the national level from the AAMC, from the Institute of Medicine on oral health. I think those factors have all worked in our favor. Some of our challenges are things that I probably don't need to talk to you about. You could probably all agree with me. Time, personnel, and one of the problems with sending our students out into the community is that most of our clinical preceptors haven't been trained, so that's a big challenge. And we've been, working on trying to address that need, but so far it still remains a challenge. All right, so we want to continue collaborating with the residencies and train our students to address dental conditions in the emergency department because that's a big issue as well, and also train them in administering dental anesthesia. All right, another thing we're planning perhaps for this summer is to have a conference for our local providers on medical and dental collaboration. And then at some point when I have the time to actually write this all up and try and get it published, in addition to presenting at other meetings like this one. So I thank you for your attention. Thank you.
Thank you all very, very much. I appreciate being invited today, and I also appreciate very much the initial funding I got from the Trade Foundation, which started me on my odyssey. And I must admit today that even as a pediatrician from the University of Minnesota, all my professional colleagues today are public health dentists, for better or for worse. So, seed money. The original grant was $8,000, and then a couple of years later came a grant for $5,000, but those dollars have been multiplied several times over by funding from other organizations, which I will highlight as I go along. My odyssey began really at the Surgeon General's Conference in 2000, the first ever Surgeon General's Conference on Oral Health in America, where I met, and that conference, for those of you, was anyone here in the room at that conference? Well, you will probably remember that the opening words of that conference, and we heard it hourly for 3 days, the mouth is part of the body. We came away with the big picture. Anyhow, at that conference, I met Olson Huff, a retired pediatrician from North Carolina, who had begun a program called Into the Mouths of Babes, where he was training primary care medical providers, pediatricians, and family medicine physicians to do caries prevention as part of the well child examination. And over dinner one night, he challenged me to go back to Minnesota and replicate what he was doing in North Carolina. So I came back to Minnesota and I called the Department of Human Services and said to the gentleman who was responsible for a dental access task force that had been started about 6 months earlier, I said, I've been challenged, will you pay? And the answer was an immediate yes. So of all the 45 states that have agreed to reimburse physicians for putting fluoride varnish on teeth as part of the well child exam, Minnesota was the easiest sell of all. Anyhow, I applied to the, at that point in time, I was interested in going in two directions. One, I had been running an FQHC in a neighborhood in Minneapolis, which has got the highest risk of any of the city's neighborhoods, and is also viewed by the American Indians who live there as the largest urban reservation in the country. It has got phenomenal risk status. Probably only about 40% of the kids graduate from high school. And the dental problems are just horrendous. And there's a school in the neighborhood, a grade school, that Anderson School, that when it was built with 3 dental operatories inside its walls. So I decided to talk to the school people about beginning a project at Anderson, trying to improve the oral health status of the kids who went to school there, but as important, to try to bring in the younger siblings of those kids who were not yet in school and the older siblings of those kids who were going to other schools. And we got the teachers involved, and we got the dentists involved, and it was going very, very well. We had a group of parents who formed a little task force to try to encourage other parents to allow their children to be treated at the school. And sadly, Minneapolis has this habit of the Board of Education of moving staff around from year to year. And after the first year at Anderson School, those who were supportive of my project were moved to other schools, and it was very difficult to engage their replacement. So the Anderson project sadly died prematurely. But at the same time, I was wanting to begin to move out into the medical field and get more physicians trained to do caries prevention as a part of well-child care. We see kids, 13 times in the first 5 years of life just for wellness care, and many, many times for episodic care. So there are multiple opportunities, to educate caregivers about caries etiology and their role in prevention, and secondly, to put varnish on the kids' teeth. And so I got additional grant money from the Trade Alliance and also from the Medica Foundation, which is one of the managed care organizations in the state, which is enrolling not only the Medicaid population, but is also doing commercial insurance. UCare, which is designed just for the Medicaid population, and then Delta Dental Foundation, and also the Trade Alliance, which seems to have gotten squeezed out by the health plans on that slide, and I apologize for that. But the goal has been to train medical providers. In that group, I put physicians, nurse practitioners, and physician assistants who are serving the high-risk kids, those eligible for Medicaid or Minnesota Care, in the rest of the country is known as CHIP, to do some caries prevention as part of the EPSDT exam. And again, Minnesota has got its own acronym, C&T standing for Child and Teen Checkup, but it's the same product. Anyhow, to train the physicians, to do a gross oral exam, eyeballing the teeth, and if it looks like a train wreck, find a consultant, i.e. a dentist who would be willing to render an opinion whether it's a train wreck or a variation of normal. Secondly, to do a 30-second risk assessment, but basically if you're on Medicaid and you have no dental home for your child, i.e. a dentist who will see the child whenever there's a problem, and regardless of what the problem is, that child's considered high risk. And then, according to the American Dental Association recommendations, the high-risk child should get anywhere from 2 to 4, but probably better 4 varnish applications a year. The third part is to do the anticipatory guidance, letting the caregivers understand the etiology of caries and their role in prevention. And I would argue that if the parent doesn't change his or her ways, the caregiver, all the varnish in the world is probably not going to make that much difference. If you're going to continue to put the kid to bed with a bottle that's got any sugar liquid in it, the varnish isn't going to make much difference. The fourth piece is to put the varnish on, and the last piece is to make sure that the caregiver understands that although there is this intervention to prevent caries, it should not be viewed as a substitute for a dental home. Even though a dental home may be hard to find, they should continue to look. And then also that the varnish is not the same as sealants. They are for different purposes, and they should not confuse one with the other. So that project is still going on in the state, but I broadened out now to be training not only individual clinics, but so many clinics are being bought up by health systems that I'm now training all the clinics of a health system. I've just finished training 35 clinics of the Fairview Health System, because Fairview has decided that that's one of their performance measures that they're going to use henceforth, and they wanted all their docs trained, or all their medical providers trained. And I've also done the Sanford system, the Sentia Care, and loon I lope to do the Mayo Health System, which has clinics scattered from the west Wisconsin to the South Dakota borders in the lower part of lower third of Minnesota. the next thing that my interest took me, the next direction it took me was the question, is a WIC site a good site to intercept high-risk kids? So I got some additional funding from UCARE and Delta Dental, and I was able to engage a trained medical Somali woman who was a trained medical interpreter and an Hispanic woman who was a trained medical interpreter. And the dental hygienist trained them on how to put the varnish on, and I trained them about educating the caregivers. And I had them in the South Minneapolis WIC clinic 2 days a week, Mondays and Wednesdays for 2 years, 8 hours a day. So in that time, a number of kids got varnishings 8 times. No mother after the first varnishing said, I don't want this again. And all that my staff did was to call the mothers the week before they were scheduled for their coupon pickup and remind them to bring their kids along, and they brought their kids, and the varnishing was done. I'm just in the process of putting together a manuscript that lays out some of the changes in behavior that we were able to document on the basis of that activity. So I think the bottom line is I think the WIC clinic is a good place to intercept the mothers. The caregiver, by WIC rules, has to come in to get the coupon. She can't send a relative or a friend. And so it's a good opportunity to educate the caregiver, and it's an easy thing to just bring the kids along. So that worked out fairly well. And the last piece of my adventure to date is creating oral health zones. An idea that was given to me by Fern Ingber, who's the CEO of the National Children's Oral Health Foundation. I got funding from her organization, and I basically carved up the state into 9 districts by drawing some lines vertically and horizontally, and then looking in each district to see which county had the largest number of Medicaid-eligible children, on the theory that the more Medicaid-eligibles there were, the more cavities there would be. And then I called the chair of the Board of County Commissioners of each one of those districts, or each one of those counties, and said, here's a project I'm doing. Would you like to participate? And universally, the answer was absolutely. We know we have a major problem with our kids and the cavities that they've got because they can't find dentists. This is in greater Minnesota, not the 7-county metropolitan area, but in greater Minnesota. And so they wanted in. So I asked the chair of the commissioners to name a link who could be the link between him or her and me. And then I asked that link to identify people in the community who would be good leaders of the stakeholder groups. And the thrust of this project is to get the stakeholders in each county/community used synonymously to take ownership of the caries problem affecting their kids. And the goal is to increase oral health literacy throughout the community. Secondly, to get all the docs, all the primary care medical providers trained to do caries prevention as part of well-child care. Now, I forgot one more element of the caries intervention is to do the lift to the lip and to show the caregivers how to do that also, so that they can continually check their kids, and if they see anything suspicious, bring the child in for the primary care provider to say it's either a variant of normal, or it's a white spot, or it's food or plaque, one or the other. But that's another, I overlooked that earlier in this talk. So right now I'm working it's very interesting. I picked Nobles County, for example, in southwestern Minnesota, and I was told, well, you can't just work with Nobles because down here, because of inadequate state funding for health and human services, we pool our resources with 6 other counties. So one county became 7 counties, and 9 counties became 40 counties around the state for the same reasons that I'm working in. And trying to get all the providers trained, get some educational materials out there, and get the docs to do the prevention. And under the watchful eye of the stakeholders, hopefully the dentists will agree that they're part of the community, and their role, because they're the only people in the town who can drill and fill or pull, that they've got to contribute their services also, and it can't just leave it up to the physicians. And in so many of these small counties, these people all know each other by first name, and they work together, they pray together, they play together, and hopefully the dentists are going to be responsive to the rest of the stakeholders in the community and say, okay, I'll do my fair share. Otherwise, the project is doomed. Although in theory, if the docs do all the right things, you can get a child to middle age with perfectly healthy teeth. And you can make dentists, like the dinosaurs, extinct, because there won't be much need for them because no one's teeth are rotting away. And these are some of the products that I have created as part of this adventure. The web-based training program is still up. It's about a 65-minute. There's no cost to look at it. I created an atlas of common dental pathology. Basically, it's the Procter & Gamble Smiles for Tomorrow program, which the university negotiated the rights to use in this book. And it's basically designed for primary care medical providers who don't recognize something in the mouth. And the pictures each has a caption underneath it, and I now have both English captions and Spanish captions so that the providers can actually show the pictures to Spanish-speaking parents, and they can read for themselves what the picture's all about. I've created 11 public service announcements which are about ready to go into prime time, and they will be played on all the radio stations in Minnesota. And they can also be printed out and made into handouts to put in doctors' clinics or grocery stores or wherever anyone wants to put handouts. And anybody in this room who wants them, just send me a note, and once they're available for prime time and they've been released, you're more than welcome to have them. They're not copyrighted by any means. I created some educational materials for different levels of complexity for primary care medical providers, for ancillary clinic staff, and for parents. I translated the post-fluoride varnish instructions into the languages of the Minneapolis-St. Paul communities. We do have the largest Somali and Hmong populations in the country. And I've told all the clinics about how to bill, how to use the risk assessment tool, a list of fluoride vendors, and a statement of myths versus realities. The person who says it'll be too tedious, and then the result is it turns out it's not tedious at all, that sort of thing. One is the myth and the other is the reality. The piece that I have not mentioned yet is one of the ideas that I've had for the stakeholder groups is I want to try to take advantage of 4-H. How many of you know what 4-H is about? Good. One of the H's stands for health, and two of their reasons for being are collaboration and communication. And I'm going to try to make advocates and a stakeholder group out of 4-H in all of the counties in which I'm working, because there's a steady stream of 4-Hers coming in. 3 leave at the end and go off to college, and 3 more come in at the 3rd grade level. So there's a steady state going on. And they can read the public service announcements. They can go to local community events and talk up oral health. And the University of Minnesota runs the 4-H program in Minnesota, and there's great enthusiasm at that level to try to make a go of getting 4-H actually very committed in this venture. So that's basically the end of my chat. I'm perfectly happy to take questions, and thank you again for the support and for inviting me here today. I appreciate it.
Hi, good afternoon. Where is the, oh, here it is. Okay. All right. Okay, I'm going to try to follow Amos. That's a tough act to follow, but I will give it my best shot. So I'm from the American Academy of Pediatrics. For those of you that aren't familiar with the organization, we are a professional organization of about 65,000 pediatricians across the country. We're located just outside of Chicago in Elk Grove Village, Illinois. And we have about 56 chapters throughout the United States and Canada. So although I'm sitting at the national office, we do have a whole network of chapters across the country. So basically what I'm tasked with at the Academy is to use pediatricians to make a difference in oral health. And for about the past 10 years, the AAP has been focusing on oral health. It was part of our strategic plan back in 2006. Basically, as a result of the Surgeon General's report, I might as well mention that since everybody else did. But we really got started in our work when we had the National Summit on Oral Health at the Academy, where we really tried to educate pediatricians about oral health and why they needed to be doing it in their practice. Following that, we had the Oral Health Initiative, which was a HRSA, Maternal Child Health Bureau, funded project that Amos was a part of, which really brought pediatricians, family physicians, and other healthcare workers together to think about how we can implement oral health services in the primary care practice. Following that, we were able to attract some funding from the Pew Charitable Trust and work in partnership with them to advocate for Medicaid payment for these services. Amos was instrumental in that process, and we are now happy to say that in 45 states we do have Medicaid payment. So one of the things that we try to do at the Academy, at least at the national office, is to use our chapters as a way to really get down to the community level in terms of training and education of pediatricians. So we were able to work with the American Dental Association Foundation. They gave us a grant for $300,000 over 3 years to train chapter oral health advocates. These were pediatricians that were invited from the chapters. So the chapters actually appointed a pediatrician in every state to come to the Academy and go through a training program. It was a day-and-a-half program where they learned about basic oral health. And then they also were able to learn how to do anticipatory guidance, counseling, and then application of fluoride varnish on staff's children. It was a lot of fun. You bring our kids in, and the pediatricians would practice on kids doing the procedure, which was great. Once the ADAF funding ended, we had this great network of chapter oral health advocates. There's about 56 of them. We didn't want to lose the momentum. So I applied for the Dental Trade Alliance Foundation grant to be able to support them in their efforts to go back to their states and train more pediatricians about how to do oral health in their practice. Just some terminology so that you know what I'm talking about, because at the AAP we like to use the alphabet soup. So AAP obviously is American Academy of Pediatrics. We call our chapter oral health advocates COHAs. The chapter advocate training on oral health was called the CATU, and from what I hear, I wasn't around then, they tried very hard to make this a CATUth, but nobody could come up with a good acronym for it. You're all familiar with DTAF and ADAF, and then if you text with any teenagers, you might know about Raffle and LOL, rolling on the floor laughing, and laugh out loud, and you'll need that in the next slide. So at first, pediatricians, were fairly resistant to the idea of even looking in the mouth. They're trained in medical school to look past the teeth towards the tonsils, and actually I messed this up. So we don't want them to do that. But when we started talking about it, they said, as Amos said, we're too busy, we don't have enough time to really address oral health in our practice. And we kind of got the same response from dentists. They laughed out loud when we talked about pediatricians doing oral health in practice. They, just weren't really quite sure how this would all fit together. But really fits together quite well. And now the AAP, in partnership with dentists, has trained hundreds of pediatricians and others to provide oral health service in the primary care practice. And when I say that, I mean oral health risk assessment, anticipatory guidance and counseling, fluoride varnish when appropriate, and referral to a dental home. I'm not talking about drilling and filling. I'm not talking about treatment. So this is just a slide to show you a little bit about the CATU. I already talked about it, so I'm not going to dwell on it. But this is what groomed our pediatricians out in the states. In 2012, we did get the Dental Trade Alliance Foundation grant, and we're able to provide awards to 12 pediatricians in 11 states. We had 2 in California, and then the others you'll see are spread across the country. These are just the names of the pediatricians who received the awards. We really made the application fairly broad in terms of what they could do. We wanted them to feel like they could design their own project according to the needs of their community. So these are the types of activities that the COHAs were able to do in their states over the year that they received funding from us. Some designed pediatric resident training programs. Some had private practice lunch and learns. We've really found, at least with pediatricians, because they're so busy, if you go to them as opposed to trying to pull them to conferences, you're able to have some success. And when you bring lunch, that always helps. We had some AAP chapter conferences that this gave the COHA the ability to say, hey, I have a little bit of funding. Can I give an oral health talk during the chapter conference? There were a few WIC office trainings, and that's been mentioned several times here. In DC, they're having some difficulty really getting the stakeholders around oral health to understand the importance of primary care addressing this topic. So they actually use their funds to host some Department of Public Health training. So just really to go to some things and educate people on why this is important. And then there were a few states that already have some really large statewide oral health initiatives going on. Pennsylvania was one of them, Colorado. So they were able to use these funds to either bring more attendees in or, have an additional talk, which was really great. So this is just an example of the resident training. What I found when I was reviewing all of the final reports from the sites, that it seems like resident training really happened in the states where pediatricians are not getting paid to do this service. So they didn't feel like they could go out to practices and educate them on something that they're then not going to get paid for. So instead, they took the funding and they started training residents, which makes a lot of sense because when they go out into practice, they can already feel like this is part of what they're supposed to do. And we know that residents will go out all across the country. So it would be helpful for them to understand oral health and be interested in it. The lunch and learning I already talked about. This is a kind of training that we use a lot at the AAP, especially at the chapter level. It seems to work very well. An expansion of this kind of learning opportunity, which I would like to explore in the future, is something called practice facilitation and the use of practice mentors. So as opposed to just going to a practice and doing a quick lunch and learn and then leaving and not really providing any support as to really how to make change in the practice, you actually would provide a practice mentor who will follow up with the practice and say, how are things going with oral health? Are you actually able to do fluoride varnish? Have you been talking to parents? How can I help you? So I think that's kind of the next wave of training, at least from the Academy's perspective, to try to better implement oral health in pediatric practices. This is one of the examples of the supplemental funds to larger initiatives. There's a lot going on in Colorado around oral health. Patty Braun, who is the woman all the way to your right, is a phenomenal pediatrician in Colorado who's doing a lot of work. And since the end of the American Dental Association Foundation funding, we haven't been able to bring COHAs to us to train them anymore. So one of the ideas was to try to leverage trainings that are going on across the country to train new COHAs. So Patty was gracious enough to invite a few new COHAs out to a training that she was already hosting in Colorado so that they could get some basic oral health education and hands-on the fluoride varnish type of training, since we're no longer able to provide that scale of training at the national office. In Utah, funds were used to sponsor oral health trainings at large primary care conferences. So he actually went outside, just pediatricians, and wanted to train family physicians who, we know are very important in terms of getting at, the populations in need, especially in rural areas. And then there was a lot of community-based training. In Northern California, funds were used to train clinic staff at community health centers in Humboldt County. In Southern California, they implemented oral health services in student-run free clinics. In Washington, D.C., as I said, they used the funds to train Department of Health employees. And then in Indiana, they focused on the WIC offices to see if there was some training that could be done there. In Minnesota, funds were used to create a brochure on fluoridated water use. As that population, that pediatrician there really found that no one was drinking tap water, which was an issue. In Utah, we had a pediatrician come, and he really knew absolutely nothing about oral health when he came to be trained as a chapter oral health advocate, which actually was the case with the majority of them. And he really just got charged up, and he went home, and he was excited about oral health. And he's actually now become the oral health director in the state. I mean, he really went from knowing absolutely nothing to doing a lot in Utah to try to change practice. So basically, the Dental Trade Alliance Foundation grant provided about $25,000, and we really were able to use those funds to continue to support the COHAs in many ways. So we had more than 971 people trained. We were able to provide free continuing medical education credit to about half of those people. We disseminated a lot of the AP oral health resources, and one thing that you helped us do was to disseminate the Pediatric Guide to Oral Health, which is a really nice flip chart that has pictures and all sorts of information on the front, and then on the back there's tips for the practitioner to talk to parents. We were able to provide free toothbrushes and toothpaste for over 5,000 children. I think a really big piece of this was just to continue the engagement of the chapter oral health advocates in their training. We really don't want to lose the momentum of those folks out in the chapters. Partnerships with WIC and other community resources, and tracking of uptake of oral health services in states, which Amos will attest to, we really need to do more of, because we need to know if pediatricians are actually doing this. So in the future, we're hoping to continue to train new COHAs and support for existing COHAs continue learning and training. One of the things that I think we learned from this grant was it was just 1 year, and we had set a $2,000 amount of money, and we think it would be more helpful if we had kind of a rolling fund where when chapter oral health advocates had an idea, they could apply and get anywhere from $200 for a speaker up to $5,000 for a bigger initiative. Utilizing the COHAs for practice facilitation and mentoring, that's one of the things I'd like to do in the future. As I said, the uptake and follow-up studies. And then, the more training and residency programs, medical schools and practices. I know Smiles for Life was mentioned. We definitely support that training, and, I think it's great to see the synergy around education across all the panels today. It seems like there's been a lot of communication and collaboration at that level. We'll continue to refine our educational resources. We're actually reprinting this flip chart right now, which will have a risk assessment tool and also a coding document included within it. I keep saying just stick a package of fluoride varnish under it and they're good to go. And then more collaborative projects that bring together medical and dental professionals. And then, of course, advocacy for payment. We still have a few states to turn over for Medicaid, and then we really need to start looking at private payers and seeing who will be able to support pediatricians providing this preventive service. So that's my beautiful little girl, and if you need more information, please feel free to contact me and check out our website. Thank you.
Thank you, Linda. I'm an old retired mayor of Martinsville, Virginia, and I can tell you one thing, it's almost 5 o'clock, and there's a few lessons that I learned as mayor, and the first one is you don't judge baby contests because you're only going to make one person happy. And the second one is you don't want to be the person that's keeping everyone in a room from getting to the 5 o'clock reception. So we're going to make sure I'm going to get you through this very quickly, and thanks to Linda for helping me to bring it into a little focus so I can zip right through this and get you to the reception where I know everybody really wants to be. I represent the drill 'em and fill 'ems here today. I'm the guy who's on the boots on the ground that's delivering care. And care doesn't come without a price. And there's always got to be a sugar daddy out there. And right now, society is not providing what they need to be doing for oral health care in this country. And we all tiptoe around the steps to try to figure out, well, we don't want to make them mad and all that. Well, the policymakers have got to step up to the plate sometime. We're the only profession, and we're getting boxed into this thing of telling us that, well, you all got to take care of that problem. Y'all going to take care of all that. Well, you don't see the drug companies out there giving away the drugs to people that need them, correct? You don't see the grocery stores giving food to people that need it. So where do they get off on the idea that they think that the dentist should be providing the care for this huge amount of people that can't afford to pay for it? It's a societal problem, and society needs to step up to play for it. So every community in this country is looking for a way to fix its dental problem, its access problem. We have a safety net problem. In our community, just about every community in this whole country has people in it that need access to care that can't get it because there isn't any money to get it. So my little town, I'll tell you about, Martinsville, Virginia, is the home of NASCAR and the real racing. Where's real racing? I invited him. As mayor, I can get him on that track, and we can make sure we can get him into a stock car and get him running around there in the best small town venue in the country. But we're known for a couple of things. We were known for NASCAR, but we were known as the manufacturing capital of Virginia. We had all the furniture and textiles. We were known as the sweatshirt capital of the world. When I graduated from dental school, 75% of this fleece that people wore in the world was manufactured in my hometown. Bassett Furniture Industry, Stanley Furniture Industry, Hunker Furniture, all these furniture companies all had people there working, and they were all beneficiaries of good dental care and good dental benefits. With globalization of the economy, wiped out our economy, the jobs fled, and now we're left behind. Our biggest distinction today, if you kind of Google us, everything pops up, is every month comes out we're the highest unemployment area in the whole state of Virginia. Have been for 10, 15 years. I don't know how far back it goes. So we've got people that need care. It became critical in 2003. You know, we'd lost our jobs. They lost their benefits. 3 years into it, people were suffering on the street. Well, people started to scream out, what do we want to do? What do we want to do? We have nothing to do. So we actually had the Virginia Dental Association, which is the father of the MOM projects, the Mission to Mercies projects. We had one in Martinsville. And the whole idea of a MOM project is not to be the fix-all of the problem. You know, in Southwest Virginia, we've got the big MOM projects, which has become their healthcare delivery system. That's not right. What a MOM project is supposed to do is focus the attention to the need for dental care for unemployed and uninsured people. You know, focus the need. And that's exactly what we did. We ran, the governor's office was involved, the state senators, the congressmen, everybody paraded through our MOM project, and they saw the need. And that led to our congressman, who asked the very simple question. He said, Mark, if there's something I can do to help y'all out to get some money for, you know, a dental clinic or something in Martinsville, I'll be glad to do it. Well, that was Congressman Virgil Goode. And Congressman Goode was on the Appropriations Committee. Well, old mayor don't look the gift horse in the mouth. He said, yes, indeed, we'll find something to get us a dental clinic. So we put together a program. After this, within about May, we sat down and met with him and told him, I said, if you get us $500,000, we'll build us a clinic. We'll raise money from our local foundations and stuff, and we'll get a clinic going, and we'll start to chip away at this huge problem that we have in the community. He called me up 3 months later, and said, he said, I'll try. I may have to split it over 2 years, but we'll try to see what we can do. So I had to get a 501c3 going, had to get first a foundation formed, then the 501c3. Well, I hadn't even had my 501c3 approved. I get the call, says, you can't say anything yet, but around Christmas time, we're going to have an announcement, you're going to get the $500,000. And it's this year's budget, the omnibus bill, incredible. I got the money quicker than I could actually get the IRS to approve the mechanism by which to receive it. So we pulled everybody together with a lot of partners, and the partners list goes on. I've eliminated that slide because it really is redundant, but one of our first partners was the dental community itself. The dentists stepped up. 80% of our dentists got involved. They got a piece of the action, and they were there. 80%. Unheard of. You don't get 80% of the physicians working in free clinics. You don't get the 80% of any profession stepping up to the plate to help the people in their community. They first made the first check that was received in our account was from the dentist. The second check that we got was from a lady who was just committed to dentistry. You know, we've got these people that really love dentistry, and her name is Marilyn Tavener. And I don't know, there may be somebody I know who's Marilyn Tavener is in the back. Marilyn Tavener is now, I guess she got approved to CMAS, and she is the director of CMAS. But then she was HCA's president in Virginia. She cut a check for $10,000. There wasn't even an HCA hospital in our community. But they stepped up to help out. She also happened to just grow up in the same county as we did. But, you know, that helps out. And you take those where you can get them. But Maryland stepped up and got us going. Delta Dental followed, and then it just, went on from there. So we started up the dental clinic, and we had to have, what's our model going to be? Our model was very simple. We needed to leverage resources. We partnered up with the dental school. I was president of the Dental Association, and we decided that we needed to do preceptorships within the community with dental students. So we got a law passed that would allow that. In Virginia, you couldn't do that. You had to have a law passed. So we had the law passed, and then that was all kind of in place. So we approached the dean and said, how can we make that work? Well, this little thing here talks about access. We needed the safety net. We needed the workforce. We needed the money. And it's always about the money. Now to make that money thing, the funding thing, the huge one, because that's what it's really all about. It's always about the money. So we put together our program. We bring in the dental students. We got an agreement with the dental school, and we train dental students. We take them, when they're in dental school, and some of the guys that are out there that work in the dental schools know what it's like in dental schools. They see 2 patients a day. It's a putsy environment. And when they come to our clinic, it's 8 patients a day. We train them how to get productive. And we do it in a way, in a state-of-the-art facility that's beautiful and just, they dream for it. They come in, it's totally unlike anything they have. We have a proctor there, sometimes a volunteer dentist there, and they all make it very efficient, because I'm a businessman, I know how to make things efficient. So we get the job done. We get 8 patients a day for these young people, so we train them in productivity. We expose them to a population that they don't get to see very often. We expose them to the population that is not present in Richmond anymore. You know, dental school's been there 100 and whatever years, and the patients, you know, they get eat up pretty quick. Out where I am, you know, my God, they got more patients they can shake a stick at. So we developed our community dental clinic with the purpose to improve the oral health of our community's citizens through oral health education and dental hygiene services. And we do that with a 2-headed goal, because our grant was for a dental education and safety net center. We have a patient goal, which is to make sure that our patients get the most access that they can for the uninsured, unemployed, and low-income adult populations. And we need to provide those students with the best possible real-life experience that they can get, so that when they leave ours, they're comfortable. We have a little discussion at the end of the day that says, you know, you can make a living in dentistry if you just did what you did today. When they walk out the door of our year, and we see only the seniors, they know that they can actually produce something to make it. This was after 3 years. This is where we were when we came to meet up with some of the folks here in the audience. But our class produced, the class of 2009, we were giving back to the community at my dental fee schedule, $532,000 a year. We gave away 38,000 diagnostic and preventive services, 1,100 fillings, 95 root canals, 1,100 poor teeth were lost. But it was time to go to the next level. And what that meant for us is we had part-time dentists, part-time facilities. When the students were there, we were there, volunteers, and paying a part-time dentist or however we did it to make it work. But we needed the full-time dentist. We needed to take it to the next level so that we could see every dental student. We only got the cream of the crop at that time. We wanted to see every student that was at VCU come through our program. And to do that, we had to have the resources to do it. And that was very fortuitous at that time, because ignore the top part of that, but the first 3 notches there is where we were. We could see that curve starting to bend down. We knew we were going to need a little shot in the arm, and we needed to take it to the next level. That's when we met Kevin Thomas at the National Oral Health Conference. I was chairman of the Council on Access at the ADA, and was at in Portland, I think, and I was graciously introduced, and he was, of course, very curious about what we were doing. I was telling him, yeah, we're getting ready, trying to get this thing to a new level. I had no idea that DTAF even existed. Didn't even know what it was. I didn't really know who Kevin was at the time. And he said, well, you got to apply for our grant. And I said, well, you know, another gift horse in the mouth. My God, I will. So here we go. I did, and we applied for the grant. It was a $25,000 grant that gave us the jump start to get it rolling. And we actually got to come to a wonderful little party up in New York, which was fantastic. Thank you all for that. It was a wonderful time. I met some folks here in the audience. But here's what it did for us. You see the $2,400, that extra money and going to the full-time thing took us up to $3,500. I don't have my thing here on, but was it $3,600, which is about a 50% increase in the number of contact visits we were able to do. The individuals that we served have constantly gone up. Value of services, incredible. I think it's a 69% increase on that. But basically, we take it all the way up. And for those of you who are in the public health sector, you know, we always worry about what the outcomes are, how we're affecting the community. And, you know, for us, on the boots on the ground, we know how many teeth we fixed. We know how many people we've prevented from having trouble, or know how many teeth that we've saved. But it's kind of hard to put your arms around of how are you impacting the community. Our community is about 72,000 people. You can see the little purple line there. 464 of the 1,971 of the people that we served that year, those are individual serves, we track them now, were returned to the community with adequate oral health, which means sort of an acceptable checkup level of gingivitis and no caries. So you see, we're making an impact. So 72,000 people, you're treating almost 2,000 of them that are in that pocket on an annual basis, and we're able to know that we've actually at least helped some people too, and hope they all have jobs next year and can come back to the private sector. But that's the reality of that we're living in now. Here's the metrics. You guys, everybody loves metrics. We went from 532,000 to 897,000, up 69%. Diagnostic services went from 3,800 to 6,000. Restorative services provided 1,100 to 2,095. almost more than doubled the amount of teeth saved with endodontic services. Surgical services, still losing a lot of teeth, but that's the environment that we're in. And where does that leave us? The student externship programs, we believe, improves dental education. It improves the student productivity from our perspective. I think a student that's able to go out with that type of experience, it was a heck of a lot better shape than it was when I graduated. It provides opportunities to treat cases that are harder to get. You know, in dental school, it's a fight to get a root canal. It's a fight to see pedo patients. You know, we were talking about that earlier. I mean, the pedo departments have to suck it up. The ortho departments all suck it up because it's all about the money. They all have to have that within their graduate programs to make that money. The students aren't getting the experience that they need. Of course, extractions are always, practice makes perfect in there, and I've still got a long way to go. Improves oral health in areas of need. It helped our community tremendously. Exposes dental students to communities beyond the dental school environment. You know, some people I call it demystification. We demystify that environment. You're going to go work in a poor community. Oh, my God. Oh, well, how do you make a living? What are you going to do? Well, it's just like practicing anywhere else. Got some different challenges, but the people in our environment love it. They love their students and love being able to get the care that they need in a high-quality way. What do we need to do with the model? And in our state, they've spread across the state. So they've kind of seen ours, and we're kind of the flagship. They've seen us and how we go. And it's done that. But across the country, you've got a lot of dental schools that are getting ready to try to start up, and a lot of them are kind of looking at this same model. And there's some other things on here that I haven't touched on about living and taking care of students in these different alternative environments. There's some serious costs that need to be thought through. But I think that every school needs to have an externship program integrated into it. And whether or not we have to dictate that through the accreditation process or through whatever other processes that we have there to do, I think it's just something that we need to think about, getting the students out of the schools, into the communities so that they're able to treat these patients. This is our performance today. This is actually a couple months behind. I'm almost positive we've tipped over the $5 million mark. And then, of course, you can see it's just exponential beyond that. We're doing it every year, $1 million a year right now. So on behalf of the kids in Martinsville, Virginia, and all those adults that are able to receive quality dental care, I thank you, DTAF, for what you've been able to do in providing the care for our students, our people in our community. And thank you very much.